Hey everyone, welcome to The Explainer. So, if you've ever stared at a new client's intake form and felt this sudden wave of panic washing over you while looking at a massive, completely unpronounceable list of medications, you are in the exact right place. We've all been there, right? Well, today we are bringing absolute clarity to exercise pharmacology. We're going to demystify those overwhelming lists and give you a highly structured, foolproof framework for keeping your clients safe. Take a look at this quote. What matters is the exercise effect, not the drug name. Seriously, I want you to internalize this right now. Let it instantly relieve your memorization anxiety. You don't need a degree in pharmacology, and you absolutely do not need to be a pharmacist to keep your clients safe. The only thing that truly matters is the exercise effect, not the fancy drug name. Okay, let's dive right into our game plan for today. First up is the exercise effect rule. Then we'll tackle managing heart medications, navigating the hypoglycemia threat, dealing with cancer drugs, and finally, we'll wrap up with the absolute highest yield exercise facts. All right, Section 1, the exercise effect rule. Focus on the outcome, not the pharmacy. Moving into Section 2, managing heart medications, specifically looking at blood pressure, heart rate, and what we call the ECG trap. So here's the big question, right? How do we quickly identify these blood pressure and heart rate manipulators without pulling out a massive medical dictionary or, needing a linguistics degree? How do we decode those complex-sounding chemical names into actual, actionable safety steps? Well, what's really interesting about this is how brilliantly these simple memory hooks translate into instant safety protocols. Think of these as your literal clinical cheat codes. Take beta blockers, for example. They end in OLO. Just remember, beta equals beat. Because they chemically block receptors to artificially blunt the heart rate, using a chest strap monitor is essentially useless for gauging their intensity. You absolutely have to use RPE, or rating of perceived exertion. Now, what about ACE inhibitors ending in pril? Just think pressure down. ARBs ending in sartan act the exact same way, just without that annoying dry cough side effect. And alpha blockers ending in osin? Think alpha equals arteries. They aggressively vasodilate to lower blood pressure. And actually, that vasodilation brings us to a massive, absolutely crucial safety caution. When your clients are on vasodilators like alpha blockers or calcium channel blockers, their blood vessels are artificially relaxed. So if you stop an exercise session abruptly, they're at a very high risk for post-exercise hypotension, which is a really dangerous drop in blood pressure. The actionable takeaway here? You must deliberately prolong their cool down to allow their system to safely adjust. Okay, let's shift gears slightly and talk about diuretics. The memory hook I want you to use here is drain. These medications basically force the kidneys to dump water and salt to lower blood volume and pressure. But think about the clinical consequence of that. This draining creates a severe dehydration risk and terrible heat tolerance. Furthermore, draining out too much potassium, a condition known as hypokalemia, can actually trigger dangerous cardiac arrhythmias. If a client on diuretics is exercising in a hot environment, intense monitoring and strict hydration protocols are completely non-negotiable. Now listen up, because this next dynamic illustrates a must-know concept for any clinical exercise physiologist. We call it the ECG trap. If you are administering a stress test, you have to watch out for digitalis, or digoxin. This drug causes a false ST segment depression on an electrocardiogram. Normally, ST depression is a huge red flag for ischemia, which is a dangerous lack of oxygen to the heart muscle. But digoxin fakes this signal. It totally confounds the exercise ECG and makes the stress test completely unreliable. All right, Section 3, the hypoglycemia threat. Navigating diabetes medications. When it comes to diabetes management in fitness, it really all boils down to one singular threat. To cut through the noise of that massive list of diabetes meds out there, we just need to ask one binary question. Which of these medications actually cause hypoglycemia, or dangerously low blood sugar, during exercise? This breakdown brilliantly illustrates the divide. On the left side, the danger zone, we have insulin and sulfonylureas. These carry a very real hypoglycemia risk because they actively lower blood glucose or stimulate insulin production. For these clients, you have to monitor glucose and strategically time their exercise against their dose and their carb intake. But over on the right, in the safe zone, drugs like metformin, SGLT2 inhibitors, and GLP-1s do not cause low blood sugar on their own. By separating these lists, you know exactly who needs a glucose check and who doesn't. Moving on to Section 4, cancer drugs and exercise. Watching for the side effects. Here again, we're not trying to memorize specific chemotherapy brand names. We're just looking for name clues that signal major exercise side effects, because our focus is entirely on managing the mechanical toll of the treatments. For instance, anthracyclines, which end in rubicin, and monoclonal antibodies ending in mAb are notorious for damaging the heart. When you see cardiotoxicity, you have to expect a significantly reduced cardiac capacity. Completely shifting gears to the extremities, taxanes, ending in Taxol, cause peripheral neuropathy, that deep, lingering numbness in the hands and feet. This tells you instantly that fall safety and balance risks have to dictate your programming. Now, zooming out a bit, almost all chemotherapy causes generally low blood cell counts, and that dictates pretty much everything we do in the gym. Low red blood cells, or anemia, means you must carefully monitor for severe fatigue and lowered exercise capacity. Low platelets, or thrombocytopenia, means a high bruising and bleeding risk, so you've got to avoid contact or heavy, sharp equipment. And low white blood cells, or neutropenia, means a severe infection risk. For these clients, everyday gym hygiene is critical, and they should completely avoid crowded gym floors. And that brings us to Section 5, Highest Yield Exercise Facts, the final review. Okay, we're in the home stretch here. Out of everything we just covered, all the suffixes, the side effects, the whole shebang, there are exactly 3 golden rules you must never, ever forget. So the crucial point is this. Burn these into your memory. Number 1, beta blockers artificially blunt the heart rate, so you must use RPE to measure intensity. Number 2, diuretics drain the system, so beware of dehydration, heat intolerance, and low potassium triggering arrhythmias. And number 3, digoxin springs the ECG trap by causing false ST depression that mimics ischemia. Seriously, if you remember nothing else from today, remember these 3 facts. Now, I do need to throw in a really quick caveat here. While we've hammered home that drug classes are what matter most, there are a handful of rare exceptions where a specific drug name carries a unique exercise-limiting side effect. For example, knowing that statins can cause severe unexplained muscle pain, or knowing that levodopa means you have to perfectly time a Parkinson's patient's exercise during their on time for optimal motor control. But again, these are the rare exceptions to the class rule. So what does this all mean for you? Tomorrow, when your next client hands you a 3-page medication list, are you going to freeze at the complex names, or are you going to look at the suffixes, identify the class, and focus entirely on the exercise effect? You have the framework to do exactly that now. Keep your clients safe, train smart, and I'll see you in the next explainer.